talking today about psychological and behavioral symptoms in movement disorders. This is kind of an emotional thought cloud here. Just going to do a quick exercise if you want to. Okay. So I want you to think back. Day you were in your doctor's office, at home, on the phone, when you first got news, you have essential tremor, you have dystonia, you have Parkinson's disease. Could be a myriad of emotions that hit you, right? But if you kind of take yourself back to that moment, I bet there were some pretty strong, intense emotions that you felt and you experienced. Or maybe not then. Maybe it was all denial. Hey, this guy's a quack. He doesn't know what he's talking about. She doesn't know what she's saying. And you went home, but it kind of came to you later and you had one of these emotions, right? So it's normal when you get that kind of that news, very traumatic, perhaps, or surprising, perhaps. But in the cases of many neurological disorders, in particular Parkinson's disease, it's also a part of the disorder. And so we'll talk about some of these emotional symptoms start long before you see your first tremor or your first shuffling gait. Okay. Sometimes 10, 15 years early. Have you heard of constipation and GI symptoms kind of being one of the early signs of Parkinson's disease? Have you heard that? No? Or REM sleep behavior disorder? Have you heard those are things that can start many years, if not decades, before your motor symptoms. By the time your motor symptoms start, the dopamine is already largely degenerated in your basal ganglia. And so some of the earliest signs can not only be constipation and REM sleep behavior disorder, where you're yelling out and screaming at your wife or your husband at night, but depression, anxiety, and apathy can be those early signs of Parkinson's disease. Okay, so these are the common types of psychological and emotional conditions that we see in dystonia, essential tremor, and Parkinson's disease. Some more than others. The first two are pretty universal with all three conditions. Okay, apathy, much more common in Parkinson's disease. Okay, psychosis was up there as well. That means you're seeing creatures running around, hearing voices, having paranoid ideations. My dad had Parkinson's disease. Okay, this is gonna get old. Technology. So my dad had Parkinson's disease. He passed away recently, but he had it for a long time, and he had psychosis with Parkinson's disease. Again, not everybody's going to get that, but some people do. And there are more risk factors than others, or some risk factors that preclude you to get psychosis more than others. But his hallucination was seeing flying cats, remote control cats, all right, with antennas on their back that were flying around the room in his living room. And they were controlled by a little boy outside with a little handheld remote. Didn't bother him. Usually don't in Parkinson's disease. Usually they're benign, right? But that was his hallucination. Okay. So psychosis, we won't talk about this as much today because that's a kind of like I said, a narrow group of people with Parkinson's disease that have psychosis, and you don't see that in essential tremor or dystonia. Okay, but I did want to include it in the list here to discuss. Impulse control disorders, again, pretty common in the setting of Parkinson's disease, less so in essential tremor and less so in dystonia. Okay, so these are the first three in particular are what we're going to be talking about, as well as impulse control disorders today. Just a quick, see, I told you I can't get away from it. This is your brain this is your brain off of dopamine, right? Remember that old campaign, this is your brain on drugs? This is your brain off of dopamine when you have Parkinson's disease, less so essential tremor and dystonia. But Parkinson's disease, as we know, is a depletion of dopamine in the substantia nigra area down here. And there are three pathways that lead from that subcortical part of the brain. All right, the mesostriatal pathway, the mesolimbic pathway, the mesocortical pathway, and the nigrostriatal pathway. So one of those pathways, the mesolimbic pathway from the substantia nigra, goes right to your limbic system. And guess what the limbic system does? It's responsible for emotions, emotional regulation. Hence, that's why you have, these emotional conditions of depression, apathy, psychosis inherent in Parkinson's disease as a symptom itself. Okay, that's why they call it a neuropsychiatric disorder. You also have one of those pathways going up to the cortex here, the frontal lobe of your brain, kind of the CEO. All right, that's that blue in there. So that pathway is going to control things like your higher level problem solving, decision making, organization, planning, the CEO of your brain, if you will. And what do we see in Parkinson's dementia? Do we see problems with memory, storage, retention? No. We see problems with those executive skills controlled by the frontal lobe. Okay, so again, even the dementia forms can vary depending on the type of neurological cause you have. So that's a little bit about Parkinson's disease, at least as a neuropsychiatric disorder. People just think it's a movement disorder. It definitely is not. In fact, you'll see that some of these non-motor symptoms, dementia, constipation, incontinence, depression, anxiety, have more of an impact on people's quality of life and disability status than their tremors. Okay, that's why I'm here, because these are really, really important things to consider. Okay. Thank you, appreciate that. So I'm going to kind of go through these first sets of slides fairly quickly, because I want to get to the crux of the presentation management, right? But just so we know what we're dealing with, this is depression. You can see in our three conditions here, the prevalence is much, much higher than what we would see, in the general population. Okay, and generally it's going to be higher in depression for patients with Parkinson's disease. But even still with essential tremor and dystonia, this cervical dystonia, we see pretty high rates of depression. So when I say depression, how is that different than just sadness, right? We've all had sadness. Sadness is normal. Sadness is usually shorter lived. You get fired from your job, you might be sad, or you might be happy. Don't know. And usually you can still go about your daily functioning. You're still getting up, you're still getting dressed, still paying the bills, things like that. But when I say clinical depression, what I'm talking about is more of a diagnostic term, all right, that encompasses a set of symptoms that exist for a very specific amount of time. So if you look at the book called Tells Us If Depression or Not, it says you need to have at least 5 symptoms that we're going to see in a minute continuously for 2 weeks, at least 2 weeks or more. Okay, so we're really looking at a constellation of symptoms, like the Big Dipper, right? Take out some of the stars, it's not a Big Dipper anymore, right? So you need kind of at least 5 of these symptoms for a diagnosis of clinical depression. And sometimes it can last just a month or two. Sometimes it can last your entire life. Your entire life. If you have more of this endogenous, chemically based, biological, vegetative, intractable depression. Okay. So it can come, it can go, it can come, it can go. Usually more intense, to the point where you may not get out of bed. You may not pay your bills. You may not take care of your kids. You may cry all the time. You may not care about really anything or your future. And it has more, even some threats to your safety if you're suicidal or you're, feeling like you want to end it all and get out of it. It can be that intense. Okay. And usually there's a continuum, just like any other syndrome, right, of mild, moderate to severe. Okay. And we categorize depression that way: mild, moderate, and severe, based on the number of symptoms you have. These are the symptoms. I kind of think about them in these 3 categories. It helps me think about depression a little bit better. clinical depression, okay? Again, now these are non-specific, so a lot of people are gonna have these symptoms, right? But we're looking at if you have enough of them together over a period of time that affects your functioning, that equates to depression. And what do you, I'm not gonna read them all because you guys can read, but what do you notice about these symptoms? Anything jump out at you? As a whole? You didn't know there was going to be a quiz, did you?
Experienced a lot of those.
Uh-huh. Okay. Well, but you kind of said what I was getting at, wanted to get at, was that these symptoms of depression, many of them are also symptoms of Parkinson's disease, right? There's a huge overlap. How many of those do you think are also symptoms of Parkinson's disease? Quite a few. Decreased concentration, bradyphrenia, forgetfulness, fatigue, loss of energy, sleep disturbance, appetite changes, restlessness, sexual dysfunction are all apathy. They're all symptoms of Parkinson's disease itself, right? So how do we know which is which? How do we know what to treat? Right, well, you're here, so you're learning, okay? But it's also up to you to dialogue with your physician so they know, hey, are we dealing with, these symptoms as a result of just Parkinson's disease, or does he really have some, or she have some coexisting depression that we need to treat separately? Because it's a whole different route of treatment, right? Whole different clinic, whole different doctor, whole different type of medications. We kind of use this category here to kind of help us distinguish. All right, with Parkinson's disease, we don't usually have as much of the affective symptoms, and it looks kind of different in the sense that with Parkinson's disease, there is less blame, less self-criticism, less guilt, less suicidality, all right, in Parkinson's depression than there is in just a normal clinical depression in your average Jane, okay? Does that make sense? So there are ways to distinguish it, but in these other categories, there's a lot of overlap there with Parkinson's itself and essential tremor itself, right? Okay. So just, again, I'm not going to spend too much time on this, but so what is depression from a patient's perspective? This is what patients have told me it feels like.
Could you read that for the people that are on Zoom?
Oh, sure. So the first one says, depression is a thief. It steals your life away. When you should be out participating in life, you're not. It's like a heavy blanket weighing you down. What am I living for? Like a black hole inside of me that I can't fill no matter what. I'm stuck in the bottom of a well. It's totally dark.
Thank you.
People, you're welcome. People tell me, I was talking to her in my ear, if you're wondering why I said you're welcome. Just realize that's kind of strange, right? So yeah, people tell me it's just heaviness, a weight, a drawing of their face, a deepness that they just can't escape. It's paralyzing. It can be really paralyzing if you're on that continuum of severe. J.K. Rowling, right? She's got a lot of controversy, I know. So this was in the slide deck well before, the recent controversy. But she says, this well-known author, everyone know J.K. Rowling? Depression is the most unpleasant thing I've ever experienced. It is the absence of being able to envisage that you will ever be cheerful again. The absence of hope, that very deadened feeling, which is so very different from feeling sad. We talked about that, right? Sad hurts, but it's a healthy feeling. It's a necessary thing to feel. Depression is very different. Okay, I don't want to get you too depressed. Okay, so this is just my, attempt at humor. So, well, John, in the past 2 years, you've gone from being extremely depressed to basically being unhappy like the rest of us. My work is done. on the other side. I think we should cut back on my antidepressant. I watched Old Yeller and it was hysterical. Did I tell you I have a friend named David? Okay. Did you guys hear that over Zoom? The David joke?
No.
Oh, you didn't? Okay. So I had this friend named David, but he lost his ID. So now we just call him Dave.
That's cute.
She said that's cute. She said that's cute. Okay, there were crickets there at first. So I was a little worried. My wife and daughter get annoyed at me. So anxiety is the next one. We'll spend less time talking about anxiety, but again, can be equally as overwhelming, impairing. We do see a lot in essential tremor and dystonia both. Okay, a lot of social-based anxiety, going out, being around people. What happens if I, have an attack or my medication wears off? And in fact, in Parkinson's disease, they're proposing a new anxiety disorder altogether that relates to off periods of Parkinson's medication. Okay, because your anxiety can really spike when your medications for Parkinson's disease wear off. Okay, so usually socially based. I have some numbers here to go with that in the Parkinson's disease. Generalized anxiety, 14%, social phobia, 13%, specific phobia, 13%, and panic disorder, 6%. So anxiety is kind of a broad category. We break it down into those different separate types of disorders. Okay. So what are the symptoms? Same categories, affective, physical, and cognitive symptoms. Again, same type of overlap with Parkinson's disease and dystonia and essential tremor, restlessness, sleep disruption, tension, fatigue, a lot of those overlapping symptoms. That's why I'm here, right? We dialogue with our physicians, providers, nurses, so we know what exactly we're treating here, okay? Is it a psychiatric condition? Is it the disease? Okay, does that all make sense so far? Any questions? Apathy, I was trying to figure out which is worse, ignorance or apathy. Then I realized I don't care, or I realized I don't know and I don't care. That was for the people at home. I don't have a lot of numbers on prevalence in essential tremor and dystonia. Parkinson's disease, it is probably just as prevalent as depression. And don't mistake apathy for depression. Okay, they're not the same thing. Apathy is not just a symptom of depression. I made that mistake early on in my career. I've been doing this about 20 years. When I first had hair and I got out of practice, I would tell people, you're depressed, you're depressed. I'm like, no, doc, I'm not. Yeah, you're depressed. My test says so. You're depressed. No, I'm not. I'm not depressed. Well, they were apathetic. Okay, and we'll talk about what that means. But from a neurobehavioral standpoint, it's kind of going back to that first slide, right? There's a chemical change in the presence of Parkinson's disease in these subcortical parts of our brain. Remember those pathways that go right up to the anterior cingulate gyrus, caudate nucleus, frontal lobe, orbital frontal lobe, that influence our motivation and our interest level and our apathy, okay? So again, we're dealing with a neurobiological change inherent in your disease, okay? So it is different from depression. It can exist separately or it can exist together with depression. But conceptually, it's a motivational disorder. I don't care. I don't want to get up. I want to watch the Louisville game. Sorry, I'd rather watch the UK game, but I just don't care. But you're somebody that watched every Louisville game, every UK game in the past. Doesn't matter now. I don't care if they win. Don't want to go to a party. If you do, they're going to leave early because it's just not, you don't get that sense of emotional pleasure from it anymore. You have this emotional blunting or emotional flatness that goes along with apathy. Okay, and your thinking, because remember those frontal executive skills and that CEO part of your brain, your intentions, your goals, your initiative, and is just kind of absent or diminished. Okay. That makes sense? How it's a separate condition? Okay. So the next slide is on impulse control disorders. This is specific to Parkinson's disease only. We do see these quite a bit in Parkinson's, usually when we have too much carbidopa-levodopa on board, or we have too many dopamine agonists on board, okay? And you can have any one of these types of impulse control disorders. Honestly, the one we see the most of in my clinic is probably what we call punding, just doing repetitive things over and over again for no real purpose. You know, it could just be lining these things up. Not out of OCD, like I need to line them up because it's bothering me, but just doing it because they need to do it. Okay, they don't get anxious by it not being messed up like an OCD, but they just line things up, organize things. And then hypersexuality, okay, which I've treated a few people with that.
Husband was hoping for that.
I'm sorry?
My husband was hoping for that.
Well, he was hoping for that, okay. Her husband was hoping for hypersexuality, but I'm sure he's not alone. But the case where I had a patient, he was getting online, and he was hooking up with hookers and getting on, meeting people, and pornography. His wife found out, their marriage was at risk. He loved her to death. He loved her to death. They'd been married for decades. He was there because he wanted to save his marriage, right? And we did, okay? Working through some of the things that we'll talk about in a minute, okay? But it was because he had too much dopamine in his medications. Part of our intervention was calling a pharmacist, saying, hey, doc, here's his medication list. What do you think? Whoa, he's on dopamine overload. Okay, we need to get this changed. And this is getting into too much of, the neurobiology again. But again, it can be neurobiological in those subcortical parts of the brain. It can also be a learning deficit. You just don't learn that that this is a bad thing because of the executive dysfunction and the kind of the feedback that breaks down. Okay, there's that CEO of your brain is not telling you this is a bad thing, because those executive skills are impaired. And of course, the medications. Those being Requip and Mirapix or dopamine agonists. So now we're trying to move into the crux of the presentation. Why are these important? We've already alluded to this. This is a huge study. I think it contained over like 20,000 different people by the National Parkinson's Foundation that 10,000, I'm sorry, from 5 different countries that they kind of collectively gathered this information about. And they determined that depression and anxiety are the #1 factors impacting the overall health of people with Parkinson's disease. The #1 factor. Not tremor, not falls, not freezing, not off periods, not pain, but depression and anxiety. Okay. Main predictor, and then other studies in the research. We're driven by our research, our knowledge of these diseases. And so studies have, again, proven that depression is the main predictor of decreased quality of life. Okay, meaning you're not as invested in life, and disability. Can't work, okay, can't go to school, can't keep your job. So depression is the #1 predictor of those 2 issues. That's pretty powerful, right? Pretty important to consider. Other reasons this is important to talk about is because your disease progression can be faster. And why is that? Well, think about the apathy and the depression and the lack of motivation we talked about. Are you going to be excited, energetic, motivated to go out to your physical therapist and do your exercises, go to Rock Steady Boxing? No, you're not. So what happens if you're not exercising or going to Rock Steady Boxing or going to refill your meds? The disease burden progresses, doesn't it? Faster. Okay, so we know that to be the case. Again, we already know it's very common. That's why it's important to be here and talk about this. We already know that there's a huge overlap between the two. So it takes education, understanding, and dialogue to be able to distinguish what do we need to treat. And in the case of my patient earlier, the last several it can have huge impacts on your marriage, finances, get arrested, or some of these impulse control problems that you might be engaging in, and caregiver burden. Your depression, your anxiety, your psychosis can affect your caregiver. How many caregivers do we have here? Yeah, my mom was a caregiver for a long time. It's a real deal, isn't it? You know, you don't want to admit that because you don't want to, express, any guilt, like, oh, I don't want to feel bad because I'm, I know he's going through it or she's going through it, not me. But caregiver burnout, caregiver depression is certainly real. I saw it in my mom. Okay, definitely. So their depression, their anxiety, their stress and strain can get worse if your symptoms aren't being treated. All right, that makes sense? I'm gonna have my wife ask me if I'm going to patent this. I might have to copyright this. All right, this is my little practical tips to beat depression, anxiety, apathy, and impulse control disorders. But this is my acronym, BEAT. Not bad, right? And it even has some rock steady boxing stuff in there. Look, I think that's a punch. Oh, well, we could imagine a punching, through the wall there, right? But be engaged is what the B stands for. E stands for exercise, A, activate, and T, treatment and thoughts, right? So we're going to keep that acronym in your mind and remember that, not only today, but going forward as well. Okay, so what does the B stand for? Be engaged. All these kind of have subgroups, right? But I mean, just be involved socially, mentally. All right, we know that it's very important to stave off depression, or I'm sorry, dementia. All right, it's very important to be socially engaged and mentally engaged and keep your mind active. All right. Support groups, that's why you're here also, right? You're not going through this alone. All right, the kind of the Yalom curative factors of group therapy, universality, hope, installation of hope, things like that. Okay, so support groups are very important, and education groups. So you gain control, you gain some sense of power, over your symptoms and your anxiety and your depression when you know what it is you're dealing with. Otherwise, sometimes it can be very overwhelming, and that sense of, I don't know what's happening to me, can exacerbate your symptoms. But once you do, through education, gives you a little more power, a little more control over things. But we talked about, right? You go out with essential tremor, dystonia, you may be socially nervous, anxious, worried, or scared. So, keep in mind, there are some things that, might help, all right, in this regard. So you think about that, and maybe it's choosing just one or two friends rather than going to a huge party. Okay. And maybe it's choosing the friends that you're closest to that you can kind of pull them aside and go, hey, look, I have essential tremor. Okay. I have dystonia. I might do some things that are unfamiliar to most people. It might mean practicing, role playing what you're going to do if you experienced increased anxiety when you're at the Christmas party. So you practice with your wife, practice with your husband, when you're starting to get super worried, anxious, panicked, how can you kind of deal with that? Is there a code word to get out? Like my wife and I at parties have a code word. It's time to go home. Okay? We do. We do. So, those are important things to consider. Yeah. So does that make sense? The mentally engagement means crosswords, puzzles, even conversations. Read the paper and talk about it, discuss it, process it. Okay. The E stands for exercise. I'm sorry, guys, I didn't have a boxing. I realized that this morning. I didn't have a boxing icon, but we're going to pretend that stretching is the same thing as boxing. Okay. Vigorous exercise, right? Exactly. I had patients that morning. I couldn't come, but I heard it was quite a vigorous exercise workout. I mean, there's no doubt about it. Now, there is really no doubt. It's clearly shown in the research. Exercise slows down the progression of Parkinson's disease, and I'd imagine it alleviates some dystonia and some central tremor symptoms as well. The research is less robust in that regard. We also know that exercise helps people with depression after they've had coronary artery bypass surgery. In HIV patients, in stroke patients, we know that when they exercise, their self-reported depression and quality of life improves. There's no doubt about it anymore in the research that exercise is an important, not curative, but certainly an important treatment for Parkinson's disease and movement disorders. Okay. Tai Chi, there's even some studies to say it helps quality of life and anxiety. Dance, there's some research to say that it helps with apathy. Okay. Although it would probably create anxiety for my wife, being so embarrassed with my poor dancing skills. Helps with apathy and quality of life. So we know that there are beneficial effects of being physically active and moving on the disease progress and progression. A stands for activate. This is kind of a long set of different things to do, but if you remember that old Nike slogan, right? Just do it. Just do it. That's what I'm talking about here. Activate these different things. So for behavior, if we think about impulse control disorders, for behavior, I want you to activate some other type of behavioral substitution other than pornography. Okay, what else can we do in that moment when you have those urge? It's called behavioral substitution. It goes way back to like B.F. Skinner and all the early behavioral psychologists, when we thought we could just condition behavior and that was it, put the rat in the box and, give it some cheese and that's it. But behavioral substitution works for impulse control disorders. Behavioral distraction works for anxiety, for psychosis. My mom would just tell my dad, "Oh, hey, look at the weather." When he would see the cat flying around. "Oh, let's look at the weather report." It works for treating psychosis as a distraction. Same with depression. Girlfriend just broke up with you, boyfriend just broke up with you, you're laying in bed. "Come on, let's get up. Let's go do something," says your friend. Okay. So those are some ideas I had on behavior. Anybody have any other ideas on what behaviors might help? Action kind of fits in that same category as behavior, and I tried to delete it, but it wouldn't let me. So I thought, well, maybe action could be a little bit different than behavior. Maybe it could be taking some proactive action by getting involved in a worthy cause related to your condition, right? Maybe it's leading a support group, exercise group. Maybe it's getting on the board of directors. Maybe it's doing some fundraising, some type of action, right? This goes directly to that apathy, right? Sense of purpose, sense of well-being, sense of reinforcement. I'm doing some good, right? Rather than the negativity associated with depression and apathy. I do want to spend some time talking about goal setting. We're going to do that just in a minute, though. I'm going to come back to that. I want to talk about coping strategies. Everybody has different coping strategies. Okay, some people, anybody repress things, don't talk about things? Oh, I'm seeing some fingers. Maybe some people talk too much about things. All right, some people are talkers, some people aren't. Maybe people write, maybe people use humor, maybe people journal, maybe people do art, maybe religion or spirituality is your coping mechanism. Activate those coping strategies. They're not silly, they're not trivial. They really do help. Don't activate the dysfunctional coping strategies, repression, right? Activate the healthy ones. Maybe your coping strategy, like me, is gathering information, becoming specialized in Parkinson's disease because my dad had it, 15 years ago. Gathering information, becoming that empowered, okay, as a coping strategy. If one doesn't work, try another one. Does that make sense? Pretty straightforward stuff. The next thing I want to talk about is relaxation and self-care. Also important stuff, okay? That might sound trivial, but these really do work, and they have a direct connection to your parasympathetic nervous system. Okay, so when we're talking about biology again, when we're anxious or we're afraid, it's a survival instinct, evolutionarily speaking, right? That fight or flight syndrome that we have. So our body starts to become more ready to fight off the predator. So our heart's racing, our pupils are dilated, our stomach has stopped processing food, our capillaries in our lungs and our blood vessels are getting bigger, right? We're ready to fight, or we're going to run away. That's called the sympathetic nervous system. We don't want that. We don't want that. In anxiety or even depression or impulse control disorders, we want the parasympathetic nervous system, the one that calms us down, okay? The one that starts to relax us, okay? So how do we get there? Well, we have to realize what we're going through. And again, if you're in that early stage, you may not know you're anxious, you're having a panic attack, or you're experiencing a nightmare, okay? But by coming here, you are learning that process, that awareness. And once you realize that, there are some things you can do. Breathe. Sounds silly, right? I'm not just talking about breathing normally like you're doing now, because that's unconscious. I'm talking about diaphragmatic breathing. All right. I call it the Dr. Underwood's rule of 3. Breathe in through your mouth for 3 seconds, hold it for 3 seconds, and out through your nose for 3 seconds. And do that for 3 minutes. It will calm you down. If we had time, I would do that. I've done other groups where we've done that. Okay. It's nice. Slows things down. And what does it do to those capillaries and to your heart rate and to your blood vessels? It kicks in that parasympathetic nervous system. You can also pair that at the same time with mental imagery as a relaxation. Imagine yourself walking down a hill towards a stream, a brook, right? It's crackling in the sunlight. All right. Mental imagery is a very powerful way of relaxing and basically the essence of hypnosis. Hypnosis is just a deep state of relaxation, and they induct you, through this mental imagery process. Okay, you can do that to yourself. All right, and you can learn that through other more professional means. Progressive muscle relaxation. I don't know if you guys do this in your workouts or not, but again, we're not just talking about just relax, but we're talking about going through a 30-minute process of tightening your toes. I won't take off my shoes, but tightening your toes. Hold that for 3 seconds. Let it out. Now tighten your whole foot. Hold that for 3 seconds. Let it out. Now tighten your calf. And you're going slower than this. And you're breathing. And you're imagining, right? And when I get through 15, 20 minutes of doing the entire body all the way up, I literally see these patients in my office just kind of like melting, sliding, going down, opening their eyes, and then they're just kind of like fuzzy. Anyone ever had a massage? Do you get that kind of like Zen kind of feeling after a massage? That's what progressive muscle relaxation can do. Massage is another way of self-care on my list here. But you can do that without paying the $70 for the hour to yourself. Okay? Very powerful way. Is that helpful to hear? Yeah, okay. So understanding how your body reacts to stress from a biological standpoint, very important, so that you can then get some power and control over reversing that process. Because if you stay in that level of engaged stress, that endured stress, that release of cortisol and adrenaline, what does that do to your body? Yeah, not good things. Okay. So goal setting, I said I wanted to come back to goal setting because again, this is kind of the, it sounds simple, it sounds easy, stupid, silly maybe, but believe me, writing a lot of treatment plans for patients in the psychiatric hospital, goals take a lot of time, and your supervisors will throw it back at you and say, this is not a behavioral, measurable, objective goal. Rewrite it. Okay. Goals should be measurable, identifiable, objective, all right, specific, We don't want them to be like way like far galaxy goals. Realistic, start small, but make them challenging enough that it's actually an achievement, right? Not too hard, not too easy, but you want to be able to see that you've accomplished it, right? And you want to come up with it on your own. There's a lot of social psychology behind, goals and whether someone else tells us to do it versus we decide to do it. And the research says what? We are more likely to do it if we decide to do it. But, all right, if we commit to someone that we're going to do it, there's even a greater chance that we're going to go through that, all right, and follow through with that goal. All right, so come up with it and then tell someone, I'm going to do this. Plan it, schedule it, where, when, how you're going to do it. Again, measurable, behavioral. Behavioral. And then give yourself some ice cream, all right? Some candy, a night out, whatever, some type of reward. These things, again, they sound silly, but they not only have a physical reaction and benefit from, the previous slide, but in this sense, it gives us more of that cognitive and affective sense of, hey, I did it. There are things in my life I have control over, when at times it probably feels like you don't have control over a lot. Okay, so that's psychological empowerment. Okay, I think we're getting close. I'm running short on time like I typically do. So I apologize for that. I don't want to keep you late here on a Saturday, but this again is pretty important stuff. So the T stands for treatment. And I've broken that down into 3 different types of treatment. Medications, non-medication treatment called cognitive behavioral therapy, and then mindfulness meditation. So medications. You're all used to taking medications, right? Probably you don't want to take any more, right? But remember that some of these conditions we're talking about today are part of the disease. If you had cancer, you would take chemotherapy, radiation, okay, to treat it. And if you don't, what's going to happen, right? Caregiver might get more stressed out and depressed. Your symptoms are going to get worse faster. Quality of life is going to go downhill, right? So I know medication is not always what people want to hear, and I'm a psychologist, so I don't want people to go on medication right away. I want to try these other things that we just talked about, relaxation and behavioral substitution and stuff like that. But there are times where you need medication. My analogy here is, for those of you who like sports, sometimes you're just so frankly depressed, like we talked about, you're stuck in the dugout. Right? You cannot get out the dugout. Coach says, come on out, and you're like, no, not playing. Medication might give you the chance, all right, to take that edge off the anxiety, to lift that spirit in the depression, to increase that motivation and apathy, to actually get on the field and learn these coping strategies we're talking about today. Then you can play the game. Does that make sense? So I've broken it down by psychiatric syndrome. I don't know how much time do you want me to go into talking about medications. I'm not a medical doctor, but I can speak to these more generally. Would that be helpful? Not really? Okay. So the only thing I'll say about those is that we need to know difference between apathy and depression, because we don't want to take an antidepressant if we just have apathy. It's going to make your apathy worse. Okay. And apathy is going to be less responsive probably to medications. So apathy is where we really want to apply the exercise, the activation, the behavioral strategies, goal settings to help with apathy, because there's no real silver bullet for apathy. You're going to see some improvement from usually the SSRIs for depression and anxiety. Okay, you have to give it time though. You need to give it time. They don't work right away. Sometimes it takes 4 to 6 weeks for your medication to work. And even then, sometimes you have to increase it or change it to a different derivative. And then I'll say also, we don't, if we can help it, want to get on a benzodiazepine. Those are bad for our memory, our cognition, our thinking, when we get to be like me over 50. Okay. And then sometimes it's not giving a medication, but taking medication away. In the case of impulse control disorders and anxiety, in the case of impulse control disorders, we might want to take away those dopamine agonists we talked about, or reduce the amount of carbidopa levodopa, because like we said, that can induce the impulsivity, hypersexuality that we're trying to, to treat. So it might be a different medication like changing carbidopa levodopa to help with the anxiety off periods, rather than adding a whole new medication for anxiety. That's the basic essence of the treatment phase or condition that we're in right now, is trying to figure out how we can release carbidopa levodopa easier, faster, smoother over time to minimize those off periods. Okay, so there are ways to adjust that to help with your off period induced anxiety. So now I do want to spend a little more time on cognitive behavioral therapy. Do y'all know what cognitive behavioral therapy is? It's a psychological term, so this is a psychologist in me coming out. It's a form of, it's a theory of, it's a type of psychological counseling or treatment. Originates from Aaron Beck and some of those people in the 80s. But basically, I mean, the essence of it is we're going to feel something, some emotion from that thought bubble, very first slide, based on how we interpret our world, ourself, our future, our past, okay? So our interpretation has a direct impact on our feelings and our behavior. If we change our interpretation, we can change how we feel. Not always easy to do, which is why sometimes you need a real psychologist to help you with this, to identify what are those automatic negative thoughts. There are several different names for those. Automatic thoughts, irrational beliefs, dysfunctional ideas. Basically you're looking at a situation in a way that is inherently negative and in a way that will promote more of a depressive or anxious reaction. All right, the example on this here is, for example, you're criticized at work. Never happened to anybody in here, I'm sure. Your boss says, I'd like you to do this differently next time. How might you interpret that? Failure. That would be one way. Okay. Or opportunity. I don't know who said that, but or you could interpret it, this is an opportunity. But if we take the first route, I'm not good enough. What thought goes through my head? I'm not good enough. I'm a failure. What does that make you feel? Angry, worthless, anxious. So if you feel that way, what kinds of things, how does your behavior change if you feel worthless, anxious? You get restless, you don't sleep, you don't eat, you avoid going back to work, you call in sick, right? That perpetuates the problem, doesn't it? All right, our physical body changes when we start to get anxious, right? We feel tired, we're not eating, and that is a circle, it's a cycle, all right? And it just kind of feeds on each other. So we have to disrupt that cycle somewhere. And this is where we disrupt it at, is the thoughts. How else can we look at that criticism? Was it really criticism? How do you know it was criticism? Okay, so what's another way to think about that? And the therapist or the psychologist will help you identify those irrational beliefs, that faulty thinking, that misinterpretation. What if it was an opportunity and you thought about it like, okay, I'm going to try and make myself better. I'm going to, improve this skill so I can be more marketable, to get a different job so I can walk out of here, right? But, is that going to have a very different, emotional response? You might feel excited. Yeah, you might feel empowered. And our behavior is going to look better. We're going to come in early. We're going to stay late. Right? See how that kind of works? It's not an easy process. Remember those people we talked about that have intractable, severe, heavy depression? It takes a long time to get at those thoughts. Yes, cognitive behavioral therapy is usually time limited, solution focused. You're not laying on the couch talking about mom with Freud for 17 years. It's usually about a 12-session process, an hour each week. You have homework. You go home and practice these skills. You do some journaling. You come back, you report your experience to the doctor. Okay. They give you feedback, and you just keep doing that over, and it's a very manualized process. So it helps some people who might be scared of going to psychotherapy or a shrink, right? It's very, again, concrete, very behavioral. And very, very empirically supported. There is no better type of form of or theory of psychology approach that has a better outcome for treating anxiety and depression than cognitive behavioral treatment. Not that some of those other relaxation methods and nurturance, self-nurturance and exercise, but CBT, and you pair it with one of those other beat ideas, then you're really in good shape. Okay? Does that make sense? This is just an example of our thinking with anxiety and without. I don't know if you can see it, but over here it says, so this is the same cycle with anxiety. So their situation here says you see a dog at the park, all right, running around in the pen. What's your thought about that? This dog's gonna attack me. So what's your emotion? Fear. So what do you do? Or what's your physical reaction? Start shaking, sweating. And then your behavior, what do? You run away. Get out of there. Darn, I was really looking forward to that. That was my chance to relax. Gosh, I suck. I'm terrible. Why did I do that? Right? Perpetuates that cycle. This is an example of CBT has intervened in the meantime. Now we're going to look at that same situation without anxiety. Okay, so you see a dog at the park. What's your thought about that dog? Yeah, what's cute? I want to pet it. It's cute. Oh, so that makes me feel happy. I'm excited. I'm energetic. I'm motivated. I'm what's the physical word for like moving forward? The adrenaline. Yeah. I'm energized. So you pet the dog. You go back home. Oh, that was fun. That was great. I'm going to do that next week. Goal setting. That's great, right? Again, not easy to do. But my example of this was always someone didn't wave to me, right? I always took that personally. Why didn't they wave to me? Why didn't they say good morning to me? What did I do wrong? Don't think that, Rob. So you have to practice this self-awareness in therapy to kind of start identifying these thinking errors. It takes some time, but pretty soon you become skilled at it. It becomes automatic. Last thing I'm going to talk about. I know I'm over time here, but I'll try and make it fast. This is new to me. It's something that I'm doing actively as we speak, and I did this morning because I wanted to do this. I wanted to learn this. It's called mindfulness meditation. There is actually some research out there to say that it has benefit in depression, anxiety, general mood subject samples, I should say. And look at the bottom one, adjustment to illness. There's some research in 2004, and there's also a more recent research study just this year, 2021, I should say. Yeah, 2021, that said mindfulness meditation is probably efficacious in those areas, and has benefits for anxiety, depression, tremor, and sleep problems. So it's kind of new. It's not kind of one of those mainstream treatments yet, but we do have some empirical support for it. So what is it? It's different than just kind of that typical meditation of that mantra you get in your mind, focus on a word, repeat the word over and over and over. That's called concentrative meditation. This is more a non-judgmental, sustained awareness of your present experience. What are you experiencing right now? Boredom? Fatigue? Excitement? But wait, that was a negative. You see, that was a negative thought, wasn't it? Boy, that was an automatic negative interpretation of my impression to you. Right? What about a positive? Yeah, exactly. I quickly at first I felt a little bit disappointed, but then I felt a little bit excited because I was going to shift it, to now I totally lost my train of thought. So you're just aware. What are you experiencing right now? I don't want you to make a judgment about it. I don't want you to make an analysis of it, an interpretation of it. I just want you to experience that you were thinking of it, non-reactive. And once you realize you're thinking of that, go back to something different. Redirect that to a different experience at that moment, at that time. Okay. Oh, that's great. That is great. Doesn't take long. Although this study I talked about in 2021 does say frequency affects efficacy. So the more you do it, you should see the slope. I don't have that slide, but the slope goes like this in terms of quality of life. I mean, there's benefit, like no matter how often you do it, but less frequent is kind of down like this, but you do it several times a day and that efficacious slope goes way up. So what you're doing is, you're really just sitting in your room, quiet space, paying attention to, maybe it's internal, maybe it's external, maybe it's sounds, temperature that you hear or see or feel, maybe it's internal thoughts or sensations in your body. Oh, my toe is kind of hurting. Okay. I'm not going to think, oh, I have what do you have on there, a goiter or something on your toe, corn or whatever. No, you're not thinking, well, what could that be? Oh, okay. Now I noticed it's kind of quiet in here. Just that awareness. And so why is that helpful? Because we're training our mind and our body not to be reactive. We're improving our self-regulation, our self-awareness, okay, our non-judgmentalness, okay? And that then does become that old B.F. Skinner behavioral learn thing. I know I'm not as like reactive to my wife when she says, put your dishes in the dishwasher. I'm just calmer. So there is a learning component to it, right? But it's interesting. It's new, kind of newer, but we do have some support for it. So I would encourage you maybe in that either end point or beginning point of your daily progressive muscle relaxation and deep breathing exercises, you try and incorporate maybe some of this into it. Now I'm just glancing at this because this is a new slide for me. Yeah, I think I covered it. So that's it. This is just other things to consider. Sometimes if we have apathy, depression, anxiety, impulse control disorders, sometimes it is something with our brain, like dementia. Okay, maybe we do need to get it checked out. Come see Dr. Underwood, Dr. Lennox, Dr. Midden at U of L. All right, we'll do a neuropsych assessment. Maybe it's a tumor, maybe it's a lesion, maybe it's a mass, on that medial frontal lobe. So rare, but things to consider. Just some closing thoughts. It's common. We know it can be part of the neuropsychiatric disease in some cases, and we know that if we don't deal with it, we don't learn about it, if we don't address it, it can make your motor symptoms worse, your quality of life worse, and your partner's life worse. So talk to your providers about it. Exercise, and then beat, right? Remember, beat. So this is kind of who we are and where we're at. Again, this is not, we don't do any therapy there. We just do evaluations and testing. Okay, so we would refer you to someone else if you wanted this CBT. Okay. But this is who we are. The two ladies, Dr. Lennox and Dr. Midden, are fresh out of fellowship, newly trained, just amazing, brilliant neuropsychologists. I'm a little older, old school, but there are three of us now. So people don't have to wait for literally 11 to 12 months to get into CS. People can wait 3 months to get into CS now. And then we have a couple psychometrists that do the testing for us. So that's a different presentation about what neuropsychology is. But that's my direct contact information. Feel free to call me, reach. Just because I don't do therapy doesn't mean I won't help you. You guys are my passion patient, all right? Because of my dad and my personal experiences, you guys are my passion patient. So I will do whatever I can to help you find the resources, or talk to Eric or Erika to help you find the resources you need to deal with any of these psychiatric issues, behavioral issues you're experiencing. So definitely email or call. Hey, that's even my direct line. I was very generous that day.
And now
Yeah, I know. Uh-oh, great. Screening my calls. All right, so that's all I have. I'm so sorry. I know we got a little bit of a late start perhaps, but I'm sorry for keeping you over about 14 minutes. But that's all I have. Any questions, I'm glad to either talk